I just only one question, Dr. Jhala. I think we see a lot of patients when we start them on ARNI or SGLT2 inhibitors. We see hemodynamic remodeling. Have you heard of this hemodynamic remodeling? Means the hemodynamics change. For example, we do E by prime ratio by echo. And when you put the patient on ARNI, the E by prime ratio is reduced. Is there any correlation with the biomarkers?
Yes, the nitrouric peptides definitely change because we have studies, especially in RNA studies, where they have used biomarkers, BNP levels, anti-pro-BNP levels as surrogate markers to identify disease response. However, unfortunately, at this stage, we do not use biomarker levels to adjust our therapy. So that concept is still not very much valid. But we can definitely segregate people who have responded by the drop in biomarkers versus non-drop in biomarkers. So those which do not respond too well, we will start thinking of alternative therapies. Maybe we will put them on a transplant list. Maybe we will consider CRT earlier. So that is how biomarkers are being used. Unfortunately, we can't use natriuretic peptides to adjust our therapy. Means if you don't add more diuretics or you don't add more things just because the anti-pro-BNP did not drop. So that stage is not there, but to a certain extent, they do guide us.
Dr. Jhala, any effect of SGLT2 or vericiguat on ST2, any data on this? And how often you require the ST2 for heart failure management? How often you do ST2?
See, I think the best thing to do about ST2 is to do it when the patient first comes to you. So you will identify if he's 35 nanograms or more, he's a high risk. And you will start implementing the 4 pillars immediately. And then after about 4 or 5 weeks, re-estimate the ST2 levels to see whether he's a responder or not. And if he's not a responder, you may start thinking of, for example, if you have not added MRE for fear of hyperkalemia or something, you will be more assured that this patient, if he has an high ST2, I have more justification of adding, for example, an MRA early. Beta blockers are also known to reduce the ST2 levels. So in a non-responder, you may optimize MRAs and beta blockers. So I think one, at the time when the patient presents to you, and second, after 3-4 weeks, once the patient has been on reasonable GDMT.
Any limitations of ST2 in prediction, or it's 100%?
No, ST2 should not be used in acute heart failure. It is more to be used for progression of disease. So it may not be very useful in predicting in an ADHF. So apart from that, there are no caveats. It is easily estimated, and the assays are fairly cheap, and they are fairly specific.
My question is, this ST2 estimation is easily available in other cities also?
Well, and in Bombay,
in metro cities only?
I would not know, because metro cities it is easily available and the cost is around 2,000 rupees.
Right. And second question is that this ST2 estimation, if we do in heart failure with reduced ejection fraction or heart failure with preserved ejection fraction, is there any difference like BNP and pro-BNP?
No, because it is basically dependent on the amount of fibrosis which is likely to happen inside, and it's a fibrosis marker. So it is equally predictive in both FPEF and FREF, both.
Thank you very much. Thank you all the chairperson, Dr. H.K. Chopra, Dr. P.C. Manoria, and esteemed speakers, Dr. Darshan Jhala, Dr. C.K. Ponde, and Dr. Jamshid Dhala.